All right, today we're going to go over some IPA techniques over sacral mobilizations and assessment. I use these pretty much on any low back that's coming through the door. It's my first go-to as opposed to going through straight for the spine. So, first thing we're going to do, we're going to start with the sacrum. Sacrum, as you know, is the triangular bone at the base of the spine. And you're going to do a spring test. What I want you to do is think about the sacrum as having 6 points to assess. So you're going to do basically the base, the middle, and towards the ILAs, and you're going to spring test both sides. On the course I just went to, the instructor said a spring test should feel, and you should only use enough pressure like you're about to bend a twig on a tree. So it's not a lot of force. The more force you're putting through your hands, you're not going to get as much feedback through them. So, what you're going to do, this is tender, you're going to find the hardest infield, and that's the area you're going to treat. The mobilization you're going to use, you're going to have them bend their whatever leg you want. Typically I do the same leg on the same side of the body. You're going to have them point their toes towards the table, and you're going to ask them you're going to have them resist basically hip flexion. So don't let me lift your leg off the table. And you're just going to hold that force until you feel it relax. You can have them relax after you hold it down for about 1 to 2 seconds, and then you can reassess that spring test. Not as tender anymore, is it? And then what you can do go back through it again, check your other spots. But typically, if you find one that has a really hard infill and you mobilize it, it typically will alleviate some of the other ones you might have found. We'll do one more right here. Bend the left leg or the right leg. Toes down, don't only lift your leg. Same thing. Perfect. And that's all you got to do. And that is sacral PDAs. Next thing I do after the sacral PDAs are I'm going to look at sacral depression. I look at this by having the patient bend both of their knees, knees together, and they're going to rock their legs side to side. Don't do it yet. But what you're feeling for, you're going to feel right at the base of the sacrum, and what you should notice, a dysfunction is if you're going to feel one side kind of move cranially. So you want to make sure that when they rock side to side that there is no movement in the sacrum. Go ahead and go for it. Okay, so his left side is dysfunctional, so what I'm going to have him do is I'm going to have him drop his legs towards the left. I'm going to have him loop his right leg around his left leg, and I'm going to have him resist his left leg with his right leg. So try to push your left leg to the left, but block it with your right leg. And then what you do is you're just mobilizing the sacrum inferiorly. Good. And then what you can have him do is after you feel the restriction release, go ahead and rock your legs side to side again. And it no longer pushes up into my hand. I feel pretty good? Yeah. So that is the sacral depression functional mobilizations. You might find that both sides are restricted, so go ahead and do both. Do one and then the other. It doesn't really matter. There's no rhyme or reason. This is all based on what you feel. Since we're up here, what we're going to do next, we're going to do, relax your legs, Leon. We're going to do an innominate depression technique. So this is the same principle as the sacral depression. You're just going to shift a little bit laterally, and you're going to be on the PSIS. Go ahead and bend both knees. And then you're going to have the patient do the same thing. Rock their legs side to side. Should not come up superiorly or cranially. It should not push up into your fingers. Okay, and it's still his left side. So drop your legs to the left. Loop your right leg around your left leg, and then push your left leg to the left, but resist it with that right leg. There we go. Okay, and then have him rock back side to side to check. And actually, his right side needs it too. So same thing on the right. Rock your legs to the right. There you go. Resist it to the right. Kick, 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 Leon, kick. Good. And then drop your legs a little bit more. And then again. I like to do a lot of quick manips once you have the patient block, so they're securing their spine and anything, they're winding it up with their muscles, so you're not going to get a lot of, you're going to manipulate straight through the area that you're desiring. You're not going to hit any accessory kind of bones. If that's not your way, you can just progressively just wind it up. So you can basically have the patient, you can mobilize it, have them relax, take up any gained range, and do the exact same thing. I just find for myself that quick little thrust seems to move it along faster, and I don't have to go through many steps. And the last technique I'll be showing y'all, go ahead and roll over on your back. It's still a sacral P to A mobilization, but this one is in a weight-bearing position. So I like to do both non-weight bearing and a weight bearing position on that sacrum, because you're going to find that patients are going to, on this side, they're going to be in multiple positions. They're never always going to be lying on their stomach unless you're working with a quadriplegic. But the next thing, what you're going to do, and this will be a little harder to show, but you're basically going to put your hands on those 3 points that I talked about earlier on one side of the sacrum. And all you're going to do is you're going to spring upwards. So what I've got my hands just kind of tucked underneath, and I'm using both hands at this time, so my left hand is going to be towards the top, and then my right index finger is going to be towards the bottom. And all I'm doing is just providing a little kind of like pressing up towards the ceiling. Okay, and then what you're going to find one side that just doesn't want to go. And in order to mobilize that, all you've got to do, have your feet together, Leon. And then all they're going to do is they're going to drop both knees away from each other. And you can kind of use some oscillations with your hand. So I'm still providing a force up, but I'm also kind of shifting back and forth, using my body weight to keep doing that. And you're just going to go back and forth, keep rocking your legs back and forth. Yep. And you're going to keep doing this until you feel the restriction give way. Which it already did. Feel it relax. So you can feel it, and the patient typically feels a lot of these mobilizations. The patient's going to say it's going to feel tender, and once you can, a good way to kind of double check if you're not quite sure if the restriction gave way, you can always ask the patient if it is as tender as it was when you started. And typically, if you get the restriction to move, or you don't have that hard infeel anymore, it's not going to be as painful. And that's really it. That's all of them. You can have the patient get up. You can see a lot of these with gait. You can notice a lot of, if these mobilizations have helped with their gait disturbances, you're going to find, a lot of lateral deviations, intalgic gait patterns. Typically will improve significantly after these techniques.